Okay, so today I have Bernie Wahl with Vikor Scientific, and I am so excited to learn more about your services and what you guys can do and how you can help us. So, can you start with a little introduction of yourself and then also Vikor Scientific?
Sure, absolutely. My name is Bernie Wahl, and I've been with Vikor Scientific now for almost 2 years since the inception of Vikor. We had a little, I'm sorry, we were involved in a research and development lab prior to that that did not want to go into the commercialization such as we did. So we kind of branched off, went into the infectious disease laboratory space, and we have become one of the premier laboratories in the nation. So we're a PCR technology laboratory, so we do molecular science, rocket science almost, I'd like to say. But unlike culture and sensitivity, our lab is not trying to grow anything. We are extracting DNA and RNA from non-invasive swabs for the full gamut of infectious disease out there. So, and I can expand on that a little bit more when we get into it.
Fantastic. And give us a little bit of your background because you said you've been with them since the inception. So, but give us a little bit about your background.
Well, I was 26 years in the car business. So
Really?
I ran Sunset Ford, which is now Peoria Ford out here in Arizona for 18 years. I was a general manager and minority owner of that store. And after 26 years, really got sick of the car business. It just wasn't fulfilling. You spent a lot of time in it, no matter how good you were or how good you ran your dealership. Nobody likes a car guy, let's put it that way. So, but we were really good at what we did. And I always taught great customer service. So we had a lot of repeat and referral business. And I think in the senior market, that's kind of what we thrive on too. So all those years in the car business taught me treat your customers well, treat your employees well, and you'll be rewarded in the end. So I got out of the car business in 2010 when we sold our dealership, and I actually went into health and wellness. So Isogenics is big out here in Chandler, Arizona. Big, well, let's call it multi-level marketing, but direct marketing. And so that's kind of how it was strange. I got approached by a gentleman who was doing PCR labs, and he said, would you consider this as a career? And I said, I know nothing about labs. I know nothing about infectious disease. I'm just an old car guy. So what makes you think that? And he said, well, you're into health and wellness with Isogenics. You like to take care of yourself. You like to make people feel better and give them an option. If you believe in something, you promote it. And that's kind of what it is. If you believe in something that's helping somebody else, that's kind of the key to moving on and having that success. So I've really, really enjoyed the senior marketplace. That's kind of my why. My mother-in-law is up in an assisted living in Salt Lake City, and she suffered from recurring UTI forever. And the psychotic events that go along with that, and believe it or not, she was actually kicked out of 3 assisted living facilities because of these events. And when I got involved in technology, we actually tested her. She was my first guinea pig. And we figured out what was going on with her that was not detectable through UACNS, culture and sensitivity, and also the antibiotic resistance of each one of those pathogens that she had recurring. And believe it or not, she's been 3 years without a urinary tract infection. So she's a completely trained person. So that's kind of my why and why I chose the senior market and what I do.
I have found that a lot too, that with the senior market, it's touched one of our lives in some shape or form. And there's just a passion there. As well as being in the senior market though, I wanted to also talk to you too, because, having chronic illness and with my support group for other individuals with chronic illness, they do oftentimes also suffer with urinary tract infections as well as our seniors. And so when I thought about this, I was like, this is really something that I want as well, anybody who suffers from chronic illness to hear as well, because I don't think sometimes we get so frustrated and then, like my mom was telling me, you end up putting on antibiotic after antibiotic after antibiotic. And so knowing that there's a solution to that, that's very appealing to me and very exciting to learn more about.
Sure. Yeah, and I chose the senior market because that's where my passion lies. But we are in primary care, we are in specialists, we're nationwide in brick and mortar as well as mobile. So we cater to all infectious disease, no matter if it's senior, no matter if it's pediatrics, every spectrum in between we cater to also.
Oh, wow.
So, like you say, that recurring or that chronic infection can affect you lifelong for sure.
For sure. So what is it about your testing that makes it different than, like you said, the culture and sensitivity for those of us that aren't familiar?
Sure. Well, culture and sensitivity, typically they are taking a sample from someone, whether it's a urine sample, whether it's a gastro sample, a respiratory sample, a wound sample, and they're sending that out to a lab. That lab is in culture and sensitivity is putting it into a petri dish and trying to grow something. It's hundreds of year old technology, 300-year-old technology, and it's the same thing. So what they are trying to do is they're trying to grow a pathogen, a culture in this petri dish. And the actual lab technician is usually looking for a visual sign. So they're looking for something to grow through a microscope. They're determining, kind of a guesswork, in my opinion, what the load of the pathogen is by the size of the circle that grows in that petri dish. So it's very, in my opinion, unscientific. It's kind of a guesswork and a visual. Unfortunately, a lot of things won't grow in a petri dish anymore. I mean, these one cell little buggers are pretty darn smart. They live in biofilms, which nothing will grow or nothing will show in culture and sensitivity in a biofilm. All wounds are biofilms. I mean, that's the snotty stuff, the pussy stuff. So nothing's going to grow in a petri dish as far as wound goes. Probably 40% of the pathogens out there won't grow in a petri dish for urine. So that's why we get our false negatives on culture and sensitivity.
Okay. Yeah.
You hear that word, false negative. So you've got Mrs. Johnson with every symptom of a urinary tract infection, the discomfort, the psychotic events, the irritability, everything that goes with that. They send out a culture, they send out a urine sample to a culture and sensitivity lab. It takes 2 days, 3 days sometimes for them to try to grow something, and then what's bugging her doesn't grow. So it comes back from the lab as a false negative. How ridiculous is that? So that's where that 60, maybe 70% precision comes in. We are 99.8%. We'd like to say 100 because we're molecular technology, but we're just not allowed to. There's some human error that could possibly be involved there. So culture sensitivity, they're trying to grow something. 30%, 40% of the pathogens will not grow in that petri dish. But if they get lucky enough to get a pathogen or two to grow in the petri dish, what they then do is introduce an antibiotic to it topically. So they put drops of an antibiotic into that petri dish and then visually try to see if that pathogen culture stops growing, stays the same size, or shrinks. And that's where they come up with the minimal amount of antibiotic that they would recommend to that patient. Here's the problem with that. They can't really tell what antibiotic resistance each one of those pathogens has because they're introducing that antibiotic outside of the human body. So it's not intermingling with the proteins, with the enzymes in the human body, whereas what we do is completely different. So, kind of to wrap up culture and sensitivity, it takes 2, 3, sometimes 5 days for something to grow or not grow. When it does grow, we're not sure we're getting all of it or we're seeing all of that because some of it will just not appear. And then the way they introduce an antibiotic to it doesn't react the same as in the human body. So that's that old technology.
And then just to interrupt briefly, oftentimes what happens is they end up putting you on an antibiotic in the interim. And it just starts this cycle.
Sure. Absolutely. Take this Cipro, take this Bactrim, take this Z-Pak. Well, whatever the broad spectrum antibiotic of the day is, they dole it out like candy.
Yeah.
Well, what it's doing is it's actually taking your the good flora in the human gut and destroying it unnecessarily, especially if these pathogens that are detected or will be detected by a lab like us are resistant to it. You might as well give somebody chiclets because it's doing about the same thing. It may it may kill some of the weaker colonies, and thus you see that irritability. You see that all those symptoms subside a little bit. But what do we see? 30, 60, 90 days, it rears its ugly head again, and we have that recurring infection going on. So, like you say, they're waiting for a result, and they're doling out that broad spectrum antibiotic right off the bat. What we do at Vikor is we have a 24 to 48 hour turnaround on our results from the time it gets to our lab in South Carolina, which we overnight FedEx everything. Wow. So if we send out a sample today, it's at our lab tomorrow at 9:30, going through the process. Excuse me. In 24 to 48 hours, it's closer to 24 now that COVID's settled down a little bit. We are getting results. So what we are doing is we're not growing anything. We're extracting DNA and RNA from those swabs, from that sample. Give you a little kind of a cool tidbit. We know how hard it is in senior care sometimes to get a clean catch. We can, I can't advocate it, but we can swab any swab that is given to us by a provider. So let's say a particular provider swabs the saturated adult brief. Right. We can test it, and we can tell the provider what pathogens we have detected.
Wow, so that's a game changer.
It's a total game changer. We know, especially in memory care, the incontinence we're dealing with, dementia patients, it's just, they just don't understand what we're asking them to do to produce a clean catch. They don't have sometimes the physical ability to produce that. So again, it is a game changer. I can't advocate it because it's not industry standard. Right. We do pick up contaminants, of course, but they'll be on a low load level that we can tell the providers. But you wouldn't believe the miracles we've discovered by swabbing a saturated brief. So
I have a feeling all of my RAL homes that are watching this or going to watch this are going to be very excited to hear that if they haven't already heard it from you.
Absolutely. Hopefully they have, or I'm not doing my job, but I always miss somebody. So once we extract that RNA and DNA and RNA from those swabs, we are able to then tell the pathogen load in multiple pathogens. I think I sent you that example, or I posted it on your page. That urine example actually had 12 pathogens detected on it. So 12 different bugs that were in this single sample. I guarantee you that if we would have ran culture and sensitivity right next to that, there probably would have been 6 detected. So again, culture and sensitivity, you may be missing out on 50% of the pathogens displayed on that. Every single one of those pathogens, instead of us looking through a microscope and trying to guess what the load is, we know exactly what the pathogen load is based on the DNA. So we can tell a provider if it's a low load, a medium load, or a high load, because we don't want to necessarily treat with an antibiotic a low load. The body's designed to fend that off. Even sometimes a medium low, it will do that. So again, we come back to that doling out of broad spectrum antibiotics and causing more harm than good. So what we want to do is we look at the medium load, the high loads, and figure out what we're going to do with those. Here's where the magic comes in. We run every single one of the detected pathogens against 49 antibiotic resistance genes. So we have the largest antibiotic resistant gene panel in the nation. Put it in layman's terms, we take bug number 1 and we run it against these genes and we go, hey, is it resistant to, tetracyclines or whatever the antibiotic is? There's so many out there. I don't even want to try to memorize all the names. But here's the neat thing. You could have 12 pathogens like that example that I sent you, and that report showed that there were 5 antibiotic resistance genes detected. Wow. So that means there's 5 broad spectrum antibiotics out there that will not cure this urinary tract infection. And most of them, when I looked at what they were resistant to, most of them were the most commonly used prescribed medications on the market.
Interesting.
So we go full circle. We actually have 22 PharmDs on our staff. And not knocking Walmart, but they're not Walmart PharmDs. These are the smartest people in the world that talk circles around me. they're the true rocket science of medical, in my opinion. But at our lab, they figure out what that pathogen load is. We also look at what the patient's allergies may be, you know, what drugs they can't handle, so on and so forth. We look at all of that. But we take those pathogens, we look at each one of the pathogens, we look at the antibiotic resistance of each one of those pathogens, and then our PharmDs actually write on our results line 1, line 2, and sometimes line 3 regimens of antibiotics. Dosage, duration, frequency. It's a turnkey prescription for the providers.
Wow, it's like a no-brainer.
It's a no-brainer. I mean, occasionally we'll have, like when respiratory hit, when COVID hit, and we went from doing 1,600 panels a day to doing 26,000 panels a day, we had to back off and use our PharmDs to actually help run labs. So we had to take that away from urine for like 6 weeks. And my providers, you would have thought that they never went to medical school because they were so on that, you know, so much on that pacifier that we provided them, which is a great thing for me to know that they find value in what we do and what we can provide them with that. And it takes, in my opinion, it takes the liability off that provider. If, you know, we all know that POAs and long-term care facilities, you know, they're always looking for a reason to, you know, bring out their fangs a little bit. And when you have mom that has recurring infection that goes on and on and on, they're the first ones to say, what the heck's going on? Why can't you cure my loved one? Well, it takes the total liability off of the provider. We can show the antibiotic resistance. We can show the PharmD report that was recommended to us. And the beauty of it is you can run a test on Mrs. Jones 2 weeks later, 3 weeks later, and actually physically show the patient and or the POA the pathogens that were there, the pathogens that are currently there, the reduction in load. It's total mathematics and science.
That's really
so it's not guesswork. And culture and sensitivity, you could never do that while a patient is on medication because it affects the results of culture and sensitivity. We don't care. It does not matter to us. They can be on 10 different prescriptions and it's not going to affect the RNA and the DNA that we extract. So,
wow, that's really impressive. Now,
that's pretty
cool. I do have a question for you. So how do I know if it was me and I was like, gosh, I keep having these recurrent, you know, urinary tract infections? How would I know if I went to my doctor? Like, do I ask them, are they using this or can I request it? Like, how does that work?
You can ask them, you know, do you use conventional UACNS, culture and sensitivity? 99% of the time they're going to say yes. It's amazing how hard it is to teach these old dogs new tricks. They've just always done culture and they just continue to do culture. It's just, they almost don't believe the results that we give them sometimes. And we've got some nationwide renowned urologists using our product that just help us, you know, send it out through the nation because they're so trusted in these forums and so on and so forth. But yeah, just ask that doctor, what form of technology are you using to detect the infection? 99% of them will say UACNS.
And then if I want to use your laboratory, how do I request that? How do I make that happen if my doctor's unfamiliar?
So we partner directly with the PCPs, with the mobile providers, with the specialists. You know, so what I would suggest in a situation like that is it might be the first time they've ever heard of it. Of course, PCR technology has reared its head because of COVID. You know, they're requiring PCR technology for COVID tests in most situations, so that it's become a common name, common everyday word that's out there, PCR. So the doctors are more and more familiar with it. They're not necessarily familiar with what levels of testing, the urine, the gastro, the respiratory, the wound, nail, vaginal, we do. I mean, the whole spectrum of everything we can do with PCR molecular technology. So in a situation like that, it would just be best to, if they're not familiar with it or they haven't been introduced to it, to just get them in contact with somebody like myself that can introduce. And then what we do is we build a partnership between the primary care physician, the mobile doc, the specialist. We build an account directly for them. It costs the physician zero money. We provide the requisition. We provide all of the sample swabs, paperwork, FedEx overnight. It's a total turnkey operation what we provide them. So it's kind of neat when they see what we do. It's pretty eye-opening.
That's really good to know. So basically, and we'll put your information at the end of the video, as well as you'll have a page on the website that people will have your contact information that they can reach out to you. But that's a good resource to know that they can just reach out to you, and then you can help have that conversation with their provider if they're looking for that. Yeah, if it's not already available. And then what about insurance? Is this covered by insurance?
Yes. So Medicare loves us. Imagine being Medicare and doling out, money month after month after month after month for medication that's not helping your patient. Of course, our technology is more expensive, but we send it to Medicare. Sometimes the patient will receive a large EOB, explanation of benefits. They never receive a bill from Medicare. That's just how we bill. We take Medicaid, so Access here in Arizona, and then we also take most major insurances. Aetna is one that doesn't pay anybody, so we steer away from Aetna. However, we will bill the patient's commercial insurance. Neat thing about Vikor is they have a compassionate billing policy. So they do not have a collection department. I know some of the local labs or some of the national labs that do UACNS, they'll send you to collections for $7.79. What we do is we bill 1.2 times Medicare to every commercial insurance. So it comes out a higher explanation of benefits. They usually chop our legs out on payment. That's what insurance companies do.
Right.
And then Vikor's policy, their compassionate billing policy is if the insurance company pays us anything, the patient responsibility is forgiven.
Wow.
What we need to do as far as a business model is we must generate 2 attempts to collect within 90 days. And then if we do not collect, we write that off. But we can't write it off. We just can't say, okay, we're going to write everybody off. Right. So the patient will receive, a attempt to collect from Vikor, but we don't have collection. We do have compassionate billing. We actually have a 800 number on the bill that they call, and they get we're in South Carolina, so they get somebody with an accent on the other end of the phone talking. They're not dialing into a collection company in a foreign country, and are guaranteed to, because that's a concern for the provider, whether it's mobile doc, whether it's assisted living, memory care, whether it's PCP or specialist, they don't want to be the bad guys as far as billing goes. So that's one of our selling points is we guarantee when that patient calls South Carolina and gets off the phone that they are happy campers. So, and I have not, in these 2 years, I have not had one patient, and I give all my providers my phone number and say, if you have a ticked off customer, you have them call me. And in 2 years, I've never had anybody call. So.
Wow, that's fantastic. That's wonderful. I do want to touch base too, because I do have some nurse practitioners that are going to be watching this that will be wanting to write orders for this as well. So if they are in with a provider or in a practice that's not currently using this, they too can reach out to you and then get set up with your services.
Absolutely.
Okay.
So I'm really big in the mobile providers out here in Arizona. Some of them are on your page. Some of them are on the, lots of the senior pages. That's how I get involved with everybody. But, Trask Mobile Medical, Mobile Valley Physicians, IHMS, IPGS, Choya Medical, the doctor is in, the list goes on and on. I am partnered directly with them. And what I do differently is I service their accounts. I basically quarterback all of their accounts. When they have an order for a patient, they fax me the order directly. I make sure the T's are crossed, the I's are dotted, everything is correct, that we've got the correct insurance information, we have the correct patient information, we have the correct ICD-10 codes, everything. And then I fax it. I have a team underneath me that goes out and does the mobile collection for me. So we go out, I had one of my gals
So
go
you
out to
actually do mobile collection, so you can do the
big mobile
in-home testing.
collection. Yep.
That is
So
fantastic. I didn't realize that.
yeah, so I had another level to that mobile doc feature is they can go out, they can do telemed, or they can see the patient in person. And when they think that we've got an infection going on, they simply dispatch to me and I take care of everything. Within 24 to 48 hours, they have results.
So Bernie, my head is starting, my wheels are turning here. So I'm with, Compasses Hospice. And so we have a palliative program, and Christy is my nurse practitioner, and I just absolutely love her. Now, could we also then partner with you, and then any of our palliative patients or even our hospice, we could use your services?
So hospice, generally, they're Part A Medicare, which we would have to, here's the problem with hospice and Part A. We would have to have an agreement between Vikor and the hospice, because hospice is going to reimburse any of the medical.
Yes, you're right. You're right.
So with that being said, I'll give you an idea. UACNS, as it's ordered today, is probably a $40 reimbursement through hospice, maybe even less. I don't know what the guidelines are. It's $275 for Vikor.
Well, that'd be a little expensive for hospice. Yeah.
A little expensive for hospice. Palliative care is all Part B.
100%. Yeah.
100%. So I'm hooked. I'm connected with Assistio, Advisacare,
Okay.
I've got the partners out there with. So I would love to partner with your palliative care.
Yeah, we need to get you in touch with our palliative program. I'm so proud of it, Bernie. So this is just a great feature. And the fact that you can go in the home and get those collections, that is wonderful, because I share this a lot in my videos, but when I'm having my flares, I'm lucky to get out of bed. So
Sure.
knowing that if I did have a urinary tract infection or anything, or if it was a respiratory infection, that you guys can come, that's fantastic. And wound care, can we talk a little bit about wounds?
Wound is one of our proudest moments at Vikor. We actually have the world's best wound panel. We detect more pathogens than any other panel in the world. And of course, we apply them against those 49 antibiotic resistance genes too. Wow. So again, like I said, on culture, wound is a biofilm. I mean, let's be blunt, the snotty, pussy, infection part of it is a biofilm. So it's very, very hard to detect pathogens when they're growing in that. Well, that's what they're growing in a wound panel. So the ability for us to take that wound swab, that non-invasive swab, and just get it wet and send it to our lab in 24 to 48 hours, be able to detect the world-class wound pathogen list, and then figure out what the antibiotic resistance is. I mean, we see it all the time. There's topical antibiotics, there's IV antibiotics, there's oral antibiotics being applied to these wound patients because it just won't go away.
Right.
Come in with a miracle test like this, it's life-changing. Totally.
That's really quite impressive. And it makes me think of, like, even with my father and how he had diabetes, and he often would end up with the ulcers and then the wounds and then the infection. Sure. And it was like, it felt like a never-ending battle for him. And it felt like it never really went away.
That's where we shine with mobile podiatry, because they are dealing with, we do nail and wound for podiatry, because they're seeing a lot of that diabetic.
Touch upon the nail for us.
So the nail, we've got one of the best panels. Most podiatrists are testing for fungus only. We're actually testing for fungus and bacteria. Okay. Most podiatrists are used to waiting 5, 7, 10, sometimes 14 days for a culture to come back, because it's really hard. And, I don't have that much experience dealing with culture on nail, but I've been told by these podiatrists, it's really hard for something to grow in that obviously they have to grind it down into a minuscule amount. We grind it when we get back to the lab too, but we're still extracting DNA and RNA. So not only fungus, but bacteria, and the same 24 to 48 hour turnaround. So I understand we're not dealing with stat measures usually with toenail fungus or bacteria, but it's nice for that podiatrist or anybody dealing with nail to be able to tout to their patients that we can get this rectified in 24 to 48 hours and figure out why a topical is not working because of the antibiotic resistance. Why well, why does it keep recurring? Why doesn't it go away? And it's mostly antibiotic resistance. So.
Yeah, that's fantastic. What is something that we haven't touched upon that you feel like, Bernie, that we need to know?
I think a lot of people aren't familiar with the term pharmacogenetics, and that is our PGX testing. So let me give you a little nutshell of what that is.
Yes.
One of our medical directors said that he thinks every child that is born should be gifted with a pharmacogenetics test. So what it is, it's a 45-second buccal swab on the inside of both cheeks. So you're just extracting those cells from the inside of the cheeks, non-invasive. It takes a little bit longer to get the results. It's usually a 7 to 10 day process to get the results. It is a once in a lifetime test. And what that test does is it provides the patient and the provider with a comprehensive look at what that patient's body, the enzymes in the liver, what their enzymes have the capacity of metabolizing currently, and the list continues to grow, currently every opioid on the market, every psychotropic med on the market, so your antidepressants, your ups and downs, every hard cancer tumor, so chemo style medication, and every blood thinner on the market right now. What it does is it prints it. The last one I saw was 19 pages long, and it tells that provider, okay, we have somebody, and we do it in pediatrics, and we do it all the way up to when you're 105, because especially in senior care, we know that these patients are on polypharm. Go into an assisted living, and Mrs. Jones' medical tray is going out, and she's got 13 meds she has to take today, or Mr. Smith has 6 meds that he has to take today. Heck, those medications could have been prescribed 20 years ago.
Yeah.
So it tells the provider that patient's ability to metabolize every single one of those drugs. Because if you can't metabolize a medication, it's simply poisoning your liver and poisoning your body and poisoning your brain. How much brain fog do we see in our lines of senior care?
So much.
So imagine we do this one-time test on Mr. Johnson, who's 75 years old. He's on blood thinner from the stroke that he had 6 years ago. He's on psychotropic meds because he's semi-depressed. He's, whatever it is, they're on multiple medications. And in a snapshot, we can tell that provider, whoa, get him off of this one, increase this one, decrease this one. We have negative interaction with these 3 and dial them in.
Wow.
We have seen memory care patients go back into assisted living. We've seen assisted go back into independent because what they thought was dementia and brain fog was the actual medication causing that brain to be poisoned and send them out of whack. So,
Bernie, is that covered by insurance, that test?
That is covered by Medicare, and it is also covered by, again, Medicare would rather know, and if somebody's on 10 different medications, take them off the 3 that aren't working, and create a better life for this person. So yeah, Medicare, it's a once in a lifetime payment. It never changes. That same test that we give to a 7-year-old because he's bouncing out the walls, and they want to put him on whatever psychotropic med it is, Ritalin or Adderall or whatever it is today, is that report is going to be the same report that a provider will use when he or she is 85, has a stroke, has a heart attack, and they want to put them on blood thinner. The same one that when they're going through their midlife crisis and they want to be put on an antidepressant or whatever it is, it's the same test. It never changes. It's a once in a lifetime gift.
Well, that's pretty phenomenal. And then most insurances generally follow Medicare's lead. So when Medicare says they generally will cover something, then you find that most commercial insurances will pick it up as well, which is good. And I'm thinking to myself in the chronic illness arena that would be a great test, especially when I'm telling you, when I was diagnosed with pericarditis, they were just throwing different things and they try to see what's going to stick. And it'd be kind of nice to know without having to go through all these different medications and side effects, and this didn't work. Yeah, to have that information.
Imagine being a, you know, I remember when my wife, the first time she was going to give my 7-year-old this little 15 milligram pill to calm his stuff down.
Yeah.
The doctor said, we're going to try this. And if it doesn't work, we're going to increase it. And then if something happens, we're going to decrease it, or we're going to change it. Like you say, you're a guinea pig and they keep throwing darts at the board. This actually dials everybody in right off the bat. So it's pretty amazing.
That's fantastic. And then, so on this test as well, does the doctor have to be partnered with you in order to run this lab, or is?
Yep.
Okay.
Yep. They would have to be partnered.
Okay, perfect.
And it doesn't have to be, here's the neat thing. We do a comprehensive panel where when you hear the word pharmacogenetics, most of the time it's a psych panel. So I have a lot of psych docs that I deal with, but they run a comprehensive panel on that patient because A, they want to know what to prescribe to them for the psychotropic meds, but they also get to see what's going on. I mean, medication can affect that, you know, what they think is a psych problem, a heart medication or another type of medication can definitely affect the human psyche. So it's really neat to see how they dial that in.
That's amazing. I'm looking on here and it looks like we have Chantel that joined us. Chantel, do you have any questions for us before we?
Hi, good afternoon. I'm a director of nursing for a national organization, and I'm just happy to be here. I'm so glad that I was able to hear this information. Do you service the East Coast?
Yes, we're nationwide.
Okay, wonderful. I missed the first few minutes of the presentation, but I certainly look forward to being in touch with you.
Fantastic. And Chantel, we're going to put his information not only on our website, Comfort Care for All, but also at the end of this video, which will be posted on our group. So we'll make sure that you get that information. Okay.
Oh, excellent. Thank you.
Bernie, what would you like to leave us with today?
I just think it's our job now, having this knowledge, to let everyone, providers, directors of nursing, executive directors, clinical directors, everybody that how important this is. I mean, literally our battle cry at Vikor is antibiotic resistance is going to kill the human race, which it will.
Yeah.
It will if we don't get a grasp on it. So I just think it's important for everybody to know if there is a technology out there that makes a difference, insurance pays for it, no questions asked, and can actually change the lives of the people we love. Why not? Why wouldn't you use it?
100%. You know what?
Not we just do things because we've always done it, but let's actually learn about new technology. I always say, listen, if you could go down the dragway in a 67 Volkswagen Beetle or, jump in a 2021 Ferrari, which would you pick? And we're the Ferraris.
I love that. And everybody has to be a voice for it, right? So not even just our providers, but, as a patient, we do have a voice. And so, speak out, tell your providers what you want, what you need, because that's what's going to help make an impact as well. So Bernie, thank you so much for joining me today. I really appreciate it. And then we're going to also have some downloads available on the website as well that people can access for more information. So
awesome.
Thank you so much.
Thanks for having me. You have a great day.
You have a great night.
Thank you.